Alrighty, I think we'll go ahead and get started. First of all, thank you to all of the attendees for joining this session. And it's with my absolute honor to welcome our guest speaker for today's session, Dr. Renee Henderson. Dr. Henderson is an assistant professor at the University of Maryland School of Medicine. He is an anesthesiologist that specializes in cardiac surgery. He graduated college from Howard University and completed medical school and residency at the University of Maryland School of Medicine. He enjoys taking care of patients, guiding them through difficult cardiac surgeries, and teaching medical students and anesthesiology residents. Dr. Henderson also has a passion for research to improve the field of anesthesia in cardiac surgery. He's interested in reducing product blood usage and kidney injury in cardiac surgery, as well as in the advancements of transesophageal echocardiography. He has been involved in multiple grant-based studies, resulting in over 20 publications. And currently, he's working on a study on cryopreserved platelets and their use in cardiac surgery. Please welcome Dr. Renee Henderson.
Great. Thank you, everyone. I hope you enjoyed the conference firstly, and then I hope you were able to log on to Pear Deck. I did put the link into the chat. So if you look at the chat and just log on onto the Pear Deck for some interactive portions of the presentation. I'm going to share my screen here. All right. All right, as you guys log on, I'll get started here. So like the great introduction, I'm Renee Henderson. I'm a cardiothoracic anesthesiologist at the University of Maryland Medical Center and associated with the School of Medicine. And today, my objective is to explain to you guys what anesthesiology is, how I became an anesthesiologist, what is like during the day, kind of a usual day for me as an anesthesiologist, and that anesthesiology is awesome. So my first question that's interactive with you guys is, what do you guys think anesthesiologists do? I see some good responses. Administer medications needed during the procedure, put patients to sleep to allow safe surgeries and procedures, monitor under anesthesia, put someone under, keep asleep and paralyzed, calculate correct dosage and deliver to the patients, reduce pain, keep patients asleep during surgery, knock people out. Yes, all these are great responses. So the next question is, how many people have actually encountered an anesthesiologist or had any surgery requiring anesthesia? Looks like the majority of people have, which is good. Hopefully I haven't seen you guys, but hope you haven't needed cardiac surgery, but I'm glad you've had an experience with anesthesia. But how was that experience for you? I'm glad the person who said the experience was awesome can't remember. Well, that's part of our job. I hope you don't remember what happened during the surgery. Didn't feel anything. I'm sorry you had an allergic reaction. Way too quick. Yeah, most patients, it's a short time for them, a longer time for us. But those are all great responses. Other than the allergic reaction, I'm glad you guys have had, a positive experience with us, and that they've done a good job for you. These answers are way better than some things we get in the hospital and things that people think the anesthesiologists do. Most people think we play Sudoku in the back or surf the internet, planning our next trip, shopping on Amazon. But my favorite one is that we're the faceless assassins. I know it's a joke and a little plug for House of Dragons coming out on the 21st, but really we are similar to the faceless assassin, that we wear many hats in the hospital and operating. We're basically the nurse back there, the pulmonologist, the cardiologist, we're the pharmacist. And we're also the internist. We're the patient advocate in the operating room to try to, let the surgeon know what's going on and keeping the patient safe and trying to get them safely through the procedure and get them going home. The second part of the faceless assassin that most patients don't really remember us as much. We meet the patients one time beforehand before going back to the operating room. We give them some medication, usually relax them before we get back. And the next thing they remember, they're in the recovery area, and we may see them during that time, but they may not remember. So that's two ways that we're a faceless assassin. But what anesthesiology really is, we're multifaceted, but one thing we are the masters of the airway. And this is not just in the operating room, this is also in the whole hospital. When there's a code or someone's coding on the floor, or there's a difficult airway on the floor, they'll call the anesthesiology team to go up, assess the patient, and try to control the airway to help the patient breathe. Same thing in the operating room. So we see patients who have tumors, masses, facial fractures, gunshot wounds that will make it difficult for the patient to breathe during the surgery, also difficult for us to control the airway during the surgery. So we have to be able to manage that during the case and do different ways to place the breathing device in the patient. So sometimes we use a camera that's on a scope to guide our breathing device in the correct place to help the patient breathe. And also during this time, obviously, we don't want the patient to remember this because that can be traumatizing to them. Next, we're the pharmacists in the operating room. There's no one to direct us and give us calculations to give the medication, and there's no one in the back mixing the medications up for us. So we're doing all that by ourselves. For transplants, we mix up the steroids that we're giving the patients. Usually the other immunosuppressants we do get from the pharmacy. We mix up our own antibiotics. We appropriate the doses for getting the patient to sleep, maintain them during surgery, and also how to give them appropriately to wake them back up. And all this time, we're still monitoring the patient's vital signs. We're making sure they're breathing correctly. We're making sure their heart rate's appropriate. And we're making sure the surgeon's happy that the patient's not moving everywhere during the operation, hindering them from doing the operation. Next, we're the pulmonologist. So we master the airway, but we also have to control the lungs and make sure the patient's able to breathe. So your lungs have two main jobs in the body. One's going to be to exchange the oxygen with the red blood cells, so you can get oxygen to your organs. And the other would be to exchange carbon dioxide so that you can get that out of the body. So our job for patients who have restrictive lung disease, so the lungs are stiff, or obstructive lung disease, means the air doesn't come out of the lungs as well, is to help appropriately ventilate them. So either slow down the rate or sometimes speed it up. Our ventilators are pretty smart, so we can adjust how much time they have in inhalation and expiration, and also how much pressure we put on the lungs at that time. Sometimes we have to administer albuterol to patients, or ipratropium, and those are different medications to basically expand the end airways of the lungs so that more exchange can happen with the red blood cells. Next, we're also cardiologists in the operating room. So I'm a cardiothoracic anesthesiologist, so I do transthoracic echocardiography and transesophageal echocardiography. So we take pictures of the heart from either the surface of the chest or also behind the heart in the esophagus. We can do that preoperatively to try to see how the patient's heart function is beforehand. And we also do the intraoperatively if the patient's struggling. And especially for cardiac surgery, we usually have a transesophageal echo probe in. And that's how we can help guide the surgeons into exactly what they need to do during the case, or it may change what the operation is. We're additionally looking at the EKG, so we're looking for new instances of myocardial infarction. So the patient's having a heart attack, then we would need to pause the surgery at an appropriate time. So have the surgeons, wrap up exactly what they're doing at that time, call the cardiologist to come down or take the patient upstairs to the catheterization lab and see exactly what the blood vessels of the heart are doing to intervene on them at that time. And we also, as we're pharmacists, we're giving medication to the patient to control their blood pressure and heart rate. So if the heart rate's too fast, we want to slow it down. If the heart rate's too slow, we'll speed it up. If their blood pressure's too high, obviously the same thing, we'll bring it down or bring it back up with different medications. And mostly with anesthesia, you think about experiencing no pain. So we're also pain experts. This is in and out of the operating room. And so in the operating room, sometimes we give pain medications to patients with that aren't going to go completely asleep. Those who are having babies, typically with vaginal deliveries, we don't put them always asleep. We put an epidural in. Some patients who are having knee replacements and some of the joint surgeries, we inject local or numbing medication around the nerves. So the area that they're operating on will be numb and the patient won't feel anything. In addition, when you're outside of the hospital at pain clinics, our anesthesiologists can put in nerve stimulators for chronic pain. We can do certain blocks for chronic or inject numbing medication in certain areas for numbing pain or for chronic pain. In addition, we can kind of burn some of those nerves in the certain areas to help with pain management as an outpatient. And lastly, we're also the founders of critical care. So if you're really wanting to do intensive care unit, you really want to have more patient interaction instead of just the beginning of the case before coming back to the operating room. You can get the best of both worlds of being in the intensive care unit, seeing the patient's family members, and still dealing with sick patients in that arena also. So one of the best things I think about anesthesia is that we see the gamut of all patients. So we see patients before they're born. So we see the maternal mother here. She's getting ready to get an epidural and probably a spinal to help with pain control during her C-section. And then once the baby's born, we also basically provide anesthesia for those patients, not in this instance once they're born, unless they have some other abnormality, but once they're born for tonsils removed, sometimes for hernias, for if it's a male and their testicles haven't dropped, they'll need surgery for those. So those patients will also see in the operating room. So we're seeing infants all the way to geriatrics. So we're seeing everyone. And in summary, so anesthesiology needs to know a little bit of everything to be able to take care of the whole patient. Like I said, we're the cardiologists, so we're definitely involved in all the cardiology information, and we need to know some of that information preoperatively so we can appropriately plan how to take care of them in the operating room. We're also a nephrologist, so we're giving sometimes for patients will have to give medication or diuretics that make them go to the bathroom during the case if we think they have too much fluid on board, or we have to give medication or give fluid back if they're not making enough urine at that time. We're also kind of a neurologist at that time also. We have, for cardiac surgery, we have different monitors to look at brain activity. In addition, we have different monitors look at how oxygen is getting to the brain during the case too. And if there's any changes in those, then we let the surgeon know so they can change their manipulation of the vessels of the neck, or give blood products, basically try to give more oxygen to the patient and try to correct the problem. We're also managing their metabolism and nutrition. So for some patients, if they're diabetic, their glucose is very high during the case, we'll administer insulin. If they're super sick patients who are septic, they're kind of at the end or the extremis of things, so they can actually process or metabolize enough glucose. So those patients will have a low, be hypoglycemic. So we'll actually give them administer glucose during the case. And we're masters of vascular access too, because during the cases we need to place certain lines or monitors in patients to help monitor their blood pressure, put in lines that we can give them medication or blood products or fluid at the same time. And we must understand some of the vascular surgery aspects of trying to support the heart with left ventricular assist devices. So a little bit about myself. I know it was in my brief bio in the beginning. So around third grade, I was interested in science. I didn't want to be a doctor at that time. I still want to be a lawyer or president at that time. I definitely don't want to be president now. But in high school, I had a personal loss. My grandfather passed away during a aortic valve replacement in a coronary bypass surgery. He ended up having a plaque that was around the aortic valve that they think dislodged and then caused a massive stroke. So at that time, I was emotional, sad, and I thought maybe I'll do malpractice law. So when I went to Howard University, I was doing my bachelor's in biology because I thought maybe I'll get my science background first, go to law school, at least so I have a little bit of base of both. But during this process, I thought maybe I can just be part of the solution. So I thought about cardiothoracic surgery. And when I originally got to University of Maryland School of Medicine, I said, well, this is awesome. My rotation was awesome. The only downside that I spent a lot of hours in the hospital. And for me, in my life decision, I wanted to have some time with my family. I wanted to be able to go to things and functions with my kids. So later on my rotations, I did an orthopedic rotation. I thought maybe I'll be an orthopedic surgeon. I've had a broken leg before playing sports. My experience was good. So maybe I can do orthopedics. But later in my later years in med school, I rotated through anesthesia. And I thought, well, this is kind of the best of both worlds. I get to do procedures. I don't really have to round too much on patients. And I still have that excitement of being in the operating room. And I have the opportunity to see my family and have a little bit more flexibility. So after choosing anesthesia, I went to anesthesia residency. And I still gravitated towards cardiac surgery. And so I did a fellowship in cardiothoracic anesthesiology. And now I'm attending at the University of Maryland. So a little bit about the day in the life of me. This is actually me in the operating room when I was I think a resident or a fellow. So our days start pretty early. The cardiac OR, usually the patients start at 6:45 a.m. So I typically need to get to the hospital around 6 a.m. or so, or maybe a little bit earlier. And that's more so I can set up the operating room and make sure everything's prepared before the patient gets in. So the first thing, there's 3 main phases of anesthesia. Induction, so getting the patient off to sleep. Maintenance, making sure they're not moving and they're not causing, and they're stable and not remember anything during the surgery. And then the last part is waking them up and getting the breathing device out. And to set that out, this is our anesthesia machine in the picture. And on the left-hand side, going from left to right, on the first on the left, you have on the bottom left, there's a laryngoscope. So that's a device that helps us look in the airway and put the breathing device into the correct place. There's an oral airway for patients who are usually difficult to mask ventilate. So when we put the mask on them, we use a bag and kind of give some extra pressure there to give oxygen prior to giving the patient the muscle relaxant so that they don't move. Looking a little bit over to the right on the bottom row, these are our adduction agents. As you can see, there's the white stuff is propofol, which is one of the common agents we give to get the patients off to sleep. And the other ones are paralytics, the ones that stop the patient from moving during the case so that the surgeon can operate correctly, and also gives us the best attempt at putting the breathing device in the correct place. Our antibiotics are in the back left here in the bottles. They haven't been drawn up yet. You have your pain medication in the middle. The fentanyl and the Versed is medication to make sure patients don't remember things during the case. Then we need to have our emergency medications, things that we need to give the patients to help their blood pressure, bring it up. And then we also have medications to reverse that relaxing or paralytic medication that we give patients so they can start breathing again on their own and are able to move. So when we take the breathing device out, we don't have to put it back in. And on the far right, there's a bear hugger. Like I said, we do multiple things in the operating room. So this is what we use to keep patients warm while they're asleep, because the operating room is a cold environment. And the medications we give actually encourage patients to lose heat through their normal, the normal physiological ways. And lastly, on top of the bear hugger is an actual endotracheal tube. So once our drugs and airway supplies are set up, we also must set up our actual anesthesia machine. So we do checks and balances. We make sure there's actually oxygen going to it, make sure the nitrous oxide is available, make sure there's no leaking in any of the circuitry of the ventilator, and to make sure everything's been checked correctly. Lastly, we'll also check our transesophageal echo machine that's on the bottom right picture. And we'll make sure that is turned on, that the patient's pulled up, that we have the appropriate transesophageal echo probe, and that is all ready to go also prior to bringing the patient back. So once that's all finished, our room is similar to our cockpit, like if you're at the airport. We have our transesophageal echo machine on the left, the patient bed in the middle. We have our electronic documenting computer on the right with our anesthesia machine, our ventilator adjustment knobs, and so that we can change how we're ventilating or helping the patient breathe. We have our vital monitor, so we can monitor their blood pressure, heart rate. We can also monitor their pressures in their lungs. And in the far right of this image, there is a monitor on top here that checks brain activity and that brain oxygen levels. And then on the bottom actually monitors the flow of blood and what your cardiac output is. And also has different things to help us guide us in managing patients and giving them medication to bring their blood pressure up, or to give them more fluid or not. And all these monitors also have red flashing lights, similar to a cockpit, to let you know when something isn't going correctly so that you can act appropriately. So now that your room is set up, there's only one thing that we need to do before taking off, and that's actually seeing the patient. And our experience with the patient is pretty brief, and I think that's one part about anesthesia that's pretty unique, that we see them at a very short amount of time. But in that time, we must inform the patient what we're actually going to do, inform them how that's going to work with the surgery, comfort them, because people are nervous about anesthesia if they haven't had surgery before, or even if they have. These are times when they're not in control and someone else is controlling their normal bodily functions. And we must reassure them that we're there the whole time. We're going to take care of them, and we're going to get them back to their loved ones. So once the patient is now ready and consented, we can bring them back into the operating room. So once in the operating room, we take those medications, the propofol, fentanyl, Versed, and the muscle relaxant, and we use a laryngoscope and intubate the patient. And now once the machine and the ventilator is doing the job of the lungs and helping the patient bring the oxygen in and get into the organs, we will then place on the top image is a schematic of a transesophageal echo probe going to the esophagus, being behind the heart. So we'll place that so that we can look at the heart function and help guide the surgeon. Also, it helps us know exactly where we're putting some of our invasive or monitoring lines. We'll put a arterial line in. This is the picture in the middle is a radial arterial line. And that helps us monitor the patient's blood pressure beat by beat, because we want to make sure that we have tight control or close control of their blood pressure to keep it pretty close to the normal level. And also we can draw blood samples from here for looking at the normal chemistries of the blood and looking to see exactly what their blood levels are. And lastly, on the bottom picture is a picture of a central line that we will place into our cardiac surgical patients so that we can give them blood, fluid, or medications to maintain their heart rate or blood pressure that shouldn't really go through a IV or a peripheral vein. So patient's asleep. This is our echo, and let me switch to my live echo here. Give me 1 second. This is a live echo feed of a patient after induction, after getting them asleep for a bypass case. And that's not normal. There's actually blood around the heart on both sides. So the heart cavity is on the left picture or left video. You can see blood around the back of the heart, in front of the heart, and the blood cavity, that little circle there, is all that's volume that's able to get around to the rest of the body, which is not enough. And the picture on the right is just a different image, just a little bit up higher, looking at more chambers of the heart, but there's still a lot of fluid there. So with this patient, we definitely need to crash or get onto cardiopulmonary bypass. So this bypass machine, it has foreign products in it. So it's basically rubber or plastic makeup, and it's foreign to the body, so it will cause the body to clot, or the blood to stick together and not go through the tubing. Prior to going to bypass, we would have to give them heparin to make their blood thin to be able to go through the tubing. And the goal of bypass is to do the job of the heart. So we're taking blood from the veins of the heart, or the venous structures, and pushing it back into the arterial section so that you can give blood and oxygen to your end organs. And this picture on the left is an actual bypass circuit that is working during the cardiopulmonary bypass, or during a cardiac case. So once the patient's on bypass, now the surgeon has the opportunity to actually complete the surgery. So they'll arrest the heart with giving potassium and adenosine and glucose, so that the muscle cells of the heart can rest. The surgeon can see very well, and he can do his sutures and close everything up and repair what he needs to. Once the surgeon's completed what he needed to do, now it's time to get off the bypass machine, so we'll wean from it. So basically the bypass will then stop pulling as much blood from the patient, and start letting the blood circulate through the patient on its own, and let the heart start to have more fluid in it, so they can send it itself to the rest of the body. Once we're separated from bypass, we'll sometimes have to stabilize the patient with blood transfusions, to make sure that they stop bleeding, and they can close the chest and get up to the ICU. And also during this time, we're making sure we're monitoring the blood pressure. We're giving appropriate medications at this time, and still monitoring the patient to make sure they're not remembering anything, and their brain activity is appropriate. So once they're stable, we take the patient to the ICU, and that's where the cardiac surgical ICU team will then take over, and get the patient prepared, and hopefully make it out the hospital for a regular coronary bypass case, usually 3 to 5 days. So, but that's not the end of my day. That's just the first case. Next, we may have a scheduled case, but I'm also at a tertiary hospital. So a lot of the times we're going to get an emergency case that comes in. Typically, it may be aortic dissection or an aneurysm. So this is when there's a tear in the wall of the artery of the major arteries that come off the heart. And that's bad because sometimes if the tear is there, then the blood flow doesn't get to some of the organs, so your kidneys, your stomach, and your intestines. The blood flow may not get to those areas, and that tissue may start to die. The only way to repair those is either to open everything up and put the patient on a bypass. But as technology has advanced, we can also repair them inside the vessels by putting a graft. In that picture on the top right, there's a graft that they put inside the arteries and just deployed that there. So that will cover up the tear, and the patient can then recover and live another day, and they can see what's going on and intervene a little bit later if anything else needs to be done. Other than dissections, we also have lung transplants. The left bottom image is a lung that's been explanted from a donor. And sometimes we like to give the lungs a little bit more time to be appropriate to give to the transplant recipient. So this is a bubble lung. So they're actually oxygenating this lung in this bubble and they're monitoring the oxygen levels in the lung. And if the oxygen levels are appropriate over time, then they'll take that lung to be placed into the transplant recipient. On the bottom right hand corner picture is a heart transplant. At Maryland, we recently did a pig heart transplant probably a couple months ago, which we don't usually do. This is not really FDA approved, but it's experimental, as there aren't as many organs available to give the patients. So this patient was an extremist and not really a candidate for a normal living donor or deceased donor heart transplant. So we used a pig heart transplant for him. He eventually passed away, but not exactly from the heart, but also from some infections. So that could be the end of the day, but since I'm at an academic institution, that is not the end of the day, because we're there to teach other anesthesiologists, medical students, and residents that also, are inspiring to be either anesthesiologists or do other things in medicine. And we do this teaching by 3 different ways. So simulation, the top right picture is a picture of one of our residents placing that endotracheal tube into the airway with that the camera that's on the end of this it's a fiber optic bronchoscope, and that's for the patients usually have difficult airways, that we're thinking it may be hard to get or use that laryngoscope to actually see anything to put the breathing device in the correct place. And so instead we use the fiber optic to look and see where we're going. And then so once we're in the airway, we can drive the breathing device in. So we simulate that in our mastery center. We also teach in the operating room. This is a picture of me as a resident being taught by one of my attendings in a neurosurgery room. And then lastly, we teach in the classroom because you can't learn everything at once. And so we're actually teaching about doing percutaneous tracheostomies, which we would do in an emergency situation. And that's when you can't get the airway or the breathing device in from above or through the mouth. So we have to typically make a little incision in the neck and put a breathing device in that area. So that brings me to my research topic. So hopefully my day is done, but in between, I do need to find time to write grants or do my IRB and try to enroll patients. So like was mentioned in my biography, most of my research right now is focused on blood transfusions and cardiac surgery. And that's important because about still greater than 50% of patients getting cardiac surgery actually get a blood transfusion. And that's about 20% of the national blood supply. And that's important because COVID-19, made a real big blood shortage nationwide because people weren't getting out to donate blood, and the blood that was in the blood banks were actually getting wasted because the surgeries weren't happening as regularly because either they had COVID or we had to lessen the amount of cases we could do because COVID patients were taking up some of the operating rooms or a lot of the ICU and intensive care unit beds. This is important for cardiac surgery because you're working around the heart, big blood vessels, so you have a likelihood of blood loss. To get on the cardiopulmonary bypass machine, you don't want air in any of those tubing because air going to your brain will be a bad thing, or air plugging up the lungs would be a bad thing. So those tubings are usually filled up with fluid, and that amount of fluid in there can sometimes dilute the blood, just like if you're diluting your juice or any type of sauce you're making in the kitchen, which makes that blood level lower and makes us have to or need to transfuse them during the case. And lastly, your blood products or your normal system gets activated while it's touching the tubing there. So your platelets start getting activated and sticking together. your coagulation cascade starts activating that time. Even though we give the patients heparin, there's still a little bit of activation there. So some of that gets kind of absorbed or eaten up during the bypass case. So what my research looked at initially was looking at autologous blood, so taking patient's own blood off during the case or prior to the start of the case, and storing that so that we can give it back to the patient once we're off the bypass machine. So you see the schematic. This is on the left-hand side, the body. It's a whole blood placement. Your blood's divided into red blood cells and plasma, and they removed a bag of blood from them. And now you're a little bit less, we do replace this fine with fluid. So you're a little bit less peach and red. So you're hemodiluted there. But when you lose that blood, it's not as concentrated of blood that you're losing. So you actually save the total amount of blood that you lose. And then you give that blood back to the patient at the end. And so hopefully that will reduce the amount of red blood cells or that we have to give to the patient. As I said, you get decreased hemodilution, so you preserve some of the coagulation factors and also some of the red blood cells. And then the blood that you're losing during the case is actually a dilute amount of blood, so you're not losing as much. And then you're preserving the platelet function because platelets get eaten up or activated by the bypass machine, and they're less functional when the patient eventually comes off the bypass machine. So looking at it mathematically, we looked at that first to see basically how much volume should we take off the patients. So this is a schematic that we did of taking off about 1.2 liters of blood from a patient. This patient does have a normal original or starting blood level or hematocrit. So we took off this big bag of blood and we simulated 3 liters of blood loss and then looked at how much mass of red blood cells they had at the end. So they have about 1,400 of red blood cells left, at least mass. And then if you look at the patient who did not have the acute normal hemodilution or the taking off blood in the beginning, they also lost the 3 liters of blood, but they lost that concentrated version. So they only have 760 grams of blood left. So they have about half. So, I mean, technically you preserve about half of the red blood cell mass, at least by the equation. So our job was then implement this, which we did at Maryland. We usually remove about 800, 900 mLs of blood from the patient after getting them to sleep and putting in all the invasive lines. And we get the patient back their usually fluid after taking out the blood off. And then we give that blood back after they get off the bypass machine. And we guide how much blood products we give, usually by viscoelastography, which is a machine that basically simulates what the blood is doing inside the patient and sees how the patient's blood is sticking together. Are their platelets working well? Are there factors missing? Or are the factors getting broken down too fast? So originally we did a retrospective or looking back at patients over a 4-year period. And then we matched those patients appropriately because it's hard to match patients that we're not enrolling forward. And what we found was there was an overall reduction in transfusion by about 20%. And that was overall transfusion. That includes in the operating room and in the ICU. In the ICU, we don't really control how they transfuse patients. So that's completely up to who the clinician is or the physician is up there. But we also saw a 60% reduction in risk of just red blood cells by themselves. But there's also a signal of 37% reduction in transfusing non-red blood cells, which would be platelets, plasma, cryoprecipitate, and fibrinogen concentrate. So to look and see exactly why we had the preservation of other blood products that weren't getting transfused to patients, we looked at a forward study. So we enrolled patients that were undergoing cardiac surgery, and we did our normal blood conservation things with removing blood in the beginning. And we looked at that viscoelastic testing to see how the blood was working in those bags and in the patient before and after we gave the blood back. And we also looked at some standard coagulation labs. And what we saw was a reduction in transfusion by about 44% in the autologous group, or the patients who we did take blood off of. And we did see improved hemostasis, or we saw signs that the viscoelastic testing was actually improved after we gave the blood products back to the patients, showing there is some preservation of these coagulation factors of platelets and things like that in that blood that we're taking off. And it's not broken down while the blood is really sitting in the bag during the case, which could happen because even patients who get blood from the blood bank, when you donate blood, that blood will sit in the blood bank for a while. And as it's sitting there, some of those factors start to stick together and decrease over time. So we wanted to make sure that that's not kind of a downside to doing the autologous blood prior to the operation. All right. So back to my objectives. So hopefully I was able to achieve some of these things today for you guys. So what anesthesiology is, I hope I answered or gave you a little better idea of what anesthesiologists do. I mentioned how I became an anesthesiologist and what drove me to be an anesthesiologist. I gave you a walkthrough, a typical day for me as an anesthesiologist. There's not always a type A dissection or a thoracic aortic dissection, but it's fairly often at Maryland since we're a tertiary hospital. And I hope I've convinced you that anesthesiology is awesome. So my last Pear Deck question would be, do you think anesthesiology is awesome now? Well, awesome. Well, I don't see any no's. So I hope I did a good job. I just want to thank you guys for sitting through the presentation, and just to know, as you're going through this process and trying to decide to do medicine and what you want to do, no, it's not really a straight path. I mean, my story tells you that I went to college wanting to do something else and still got into medicine, and then even going through medical school residency, your ideas change on what you want to do, and you just choose the best path that you think will give you the most satisfaction in life. Thank you, guys.
No, thank you, Dr. Henderson. That was an amazing presentation. I guess we can go ahead with the Q&A section of our session now. Again, for all of our attendees, if you have any questions, please throw them into the Q&A section, and please upvote any ones that you also want to see answered. I'm just going to be going through the most upvoted questions as well. So let's start with this one I saw. Yeah. With so much breadth in your field, how do you have enough time to be an expert in everything?
So that's I think we're sort of brief experts in everything. So that's kind of the hard part of anesthesia, that you have to have a breadth of knowledge to do a little bit of everything. And I was telling my residents this past week that even, we need to know what we're doing for anesthesia, but you also need to know what the surgeon's doing, because that way, the hospital runs on making money, and a surgery center also runs on making money. So you have to get the patient to sleep and also wake them up as quickly and safely as possible. So you need to know what the surgeon's actually doing to wake them up in that process too. So you just have to know a good amount of things, and there's no real other way around it. But as things are going in medicine, you do specialize a little bit. So I did specialize in cardiothoracic anesthesiology. So I'm currently actually 100% cardiac anesthesia. So I do multi-cardiac cases. I don't do too many peds anymore. I do thoracic and vascular surgery. So kind of the bigger cases. So in that aspect, you do get to focus a little bit, but that's only because my job allows for that. But if you do private practice, you may still have to do pediatrics and still be able to do some of those other things.
I see. Thank you. The next question is, How is your work-life boundary, and do you have enough time and flexibility to pursue other passions?
Yeah, that's I think in medicine, that's the hard part of anyone's job, is work-life balance, and especially with the pandemic. I think everyone's trying to find that balance. And I think I've been finding a better balance of that, especially with trying to be in the operating room and doing research and also the teaching aspect. So one thing is to learn how to delegate things. That's a one pinpoint in also learning how to say no to some opportunities. I know early on, everyone wants to say, yes, I can do it. Yes, I can do it. And just pile it on and say, well, it's only a week. It's only a month. It's only a year. But sometimes you have to start balancing things and making sure that you're happy about what you're doing. And lastly, I think definitely taking time off. I just took vacation to Florida and took my kids to Disney World. So I'm making sure I'm taking my vacation days, because your job gives them to you, or you earn them. They're not given to you. You earn them by working. So you need to use those to try to separate yourself from work. And when you're on vacation, try not to answer emails, phone calls from work, because that's your protected time. So you have to really try to draw that boundary, which I've working on. And I think I'm becoming more successful at.
Nice, nice. Thank you. The next question is, what has your experience been like working in critical care, especially dealing with that emotional pressure or that fatigue?
So that's it's the fatigue is hard. So you have to take that time off. I think that's the only way you can do it. If you're having it depends on where you're working, but at least my work environment, when we have a difficult case or if there's a complication in the operator, I'm not saying it's from us, not saying it's from the surgeon, just could be the patient. But our department actually supports us in that. So, if you really need to take some days off or take a day off here and there to kind of realign yourself and kind of get around what exactly happened at that time, then that's available. And especially with the pandemic and everyone, having extra pressures at home and not wanting to get your family infected and not wanting to spread it to your parents or give it to your kids. They've established a way for not only with the physicians but also the medical students, avenues to actually talk about those things with different staff and trying to get those ideas out to what's going on and to give you support in any avenues that you need.
Awesome, thank you. Let's see. So the next question, I think this was early in the presentation. So with the airway control part of your job, would you say there's an overlap with respiratory therapy as well?
So respiratory therapy, they don't intubate patients. So that'll be the anesthesiologist that comes to do that. Respiratory therapy does manage the ventilator, at least in the ICU, but they don't manage the ventilator in the operating room. So there is some overlap, I guess, in the ICU where they usually can manage the ventilator, but it's simply going to be still the physician who kind of makes that decision on what the ventilator settings are going to be, and they can kind of, that's a delegation portion, and have them basically adjust the ventilator numbers and sometimes help the patient wean from the ventilator by giving a spontaneous breathing trial. So there's not a lot of overlap, but there is some delegation, I guess, in the ICU.
Thank you. Thank you. The next question, how often do you conduct research and publish? Do you find that others in your specific field are also publishing or only practicing?
I think at an academic institution, it's a goal for you to publish and still do research. I think, at least at Maryland, our group is pretty productive. There's probably about 3 or 4 of us out of, at least in the cardiac anesthesiology group, there's 3 or 4 of us that are pretty active in doing research out of 12 to 16 or attendings. So it's not a large amount of us, but it's a small group of us that are fairly active. And it's hard in any type of work environment, because if I'm doing research, then I can't really be taking care of the patient the whole time. So you need to have that support from your department and the staff around you to help you out so that you can be in your office doing what you need to do to write the grant or write the IRB and enroll patients. Unless you have a large amount of money to hire staff to do the consenting and do those things. To do it yourself, you need more time. So you need that balance. But I think our department's pretty good. But if you don't have to do research, if you don't want to, you can work and do more of the teaching aspect if you're still like academic institutions. So it kind of depends on what actually drives you in medicine.
Cool, thank you. This one I think concerns more of your job or your career, but do you prefer the more cerebral aspects of your job, like doing calculations, designing anesthetic plans, etc., or do you prefer the more hands-on tasks like the patient interaction, intubations, etc.?
That's a hard one. I think probably it's probably 50-50. I don't know. I like the hands-on portion. That's why I wanted to do something that was more hands-on than nothing against internal medicine, but they don't usually do a lot of procedures. And I don't like rounding. That's just something I don't really like doing. So that's why I like anesthesia. I like being the OR. I can see the patient, do my procedures. And even while I'm doing my procedures, there's still a cerebral aspect to that because we have patients that come in for cardiac surgery who are on dialysis, who have different fistulas for dialysis access. They've been had a lot of central lines or access placed in before. So I have to think about where I'm going to place that line before the patient comes into the operating room. And then I have to think about what the surgery is and what lines I'm going to actually put in and which ones do I need and where do I need to put them because I can't put it right where the surgeon's actually going to be working. And then once they're asleep, now I'm thinking about making sure I'm taking all the blood correctly. Then I'm making sure they're still balanced and giving the fluid back. And then I'm still doing my echocardiography and looking at the function and trying to help the surgeon know exactly what's going on with the patient and if they need to change their surgical plan. Because a lot of times we'll get patients who have infective endocarditis. So they have infection in their bloodstream and it usually sticks to one of the valves of the heart. And the surface echo, the transthoracic echo may show that there's just basically a infection or a vegetation on that valve. And then when we do the transesophageal one, there may actually be an abscess or infection growing in the wall of the aorta. So then that changes the surgical plan. They can't just replace the valve. They actually have to replace part of the aorta. So I have to, cerebrally think about what I'm seeing while managing the patient. So it's a lot of multitasking, which I think I enjoy more than just the cerebral or doing the procedures by themselves.
I see. And I think that was our time is up. But thank you again so much, Dr. Henderson. We greatly appreciate you coming to speak here. And thank you to all the attendees for attending this talk. I obviously, like many of you, probably found it a very, very interesting talk to listen to. And it was nice to see the day in the life of an anesthesiologist specializing in cardiac surgery as yourself. So thank you so much for coming out to speak. And thank you to all of our attendees. I hope you look forward to the rest of the conference for today. We've got one more session coming up next, and then we've also got day 3 coming up. But yes, thank you guys so much. And Dr. Henderson, again, cannot thank you enough. Thank you.
No problem. Thank you guys. Enjoy the rest of the conference.
Alrighty, I will end the webinar here. Thank you again, Dr. Henderson.
Oh, no problem.
I greatly appreciate it.
No problem. Thank you guys. This is pretty nice that you're doing this for all the the students and and hopefully gear them up to what they're actually going to expect when they hopefully get to medical school and work their way up.
That is the hope.
Yeah.
Just being able to see all of this stuff it makes more of a difference than you could ever imagine.
Awesome. Well, thank you guys for thank you for having me to come and speak, and hopefully the rest of the conference goes well too.
Hopefully. Thank you so much again. And yeah, thank you to all of our attendees. I will close the webinar right now. But thank you, everybody. Have a good one.